Welcome to this webinar on the new normal, resuming fertility care in the COVID world. I am Sarah Ramaya, Curriculum Designer at ASRM, along with my colleague Jessica Goldstein. Joining us are panelists Dr. Heather Hipp, Dr. Andy Huang, Dr. Emily Youngheim, Dr. Brad Senstra, and our moderator, Kaylin Silverberg. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment to determine a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Let me introduce our moderator for today, Dr. Kaylin Silverberg. Dr. Silverberg is the medical director and managing partner of Texas Fertility Center. He's also a co-founder and board member of Ovation Fertility and Ovation Genetics. Dr. Silverberg, over to you.
Well, thank you very much. I really appreciate everybody being here today. We're really happy to have this opportunity to speak with you. And without any further ado, I think we're going to roll right into the first presentation. What we're going to do is we're going to have different presentations here, and then you'll have a chance to ask questions. We'll be able to moderate those questions to be able to get to them as many as possible. We're going to start off, I think, with Heather. So Heather Hipp is an assistant professor at Emory University School of Medicine. She's the director of third-party reproduction for the Emory Reproductive Center, and she serves as the assistant program director for the Emory REI Fellowship, as well as a subspecialty resident educator for the GYN and OB residency. Heather, thank you so much for joining us today, and we look forward to hearing your presentation.
Dr. Silverberg, thank you so much for the introduction, and thank y'all for having me here to present today. I have no disclosures. So I am one of the faculty members at the Emory Reproductive Center. We're an academic practice located within the Emory University School of Medicine. Our center has two different offices. One of our offices is at Emory Midtown Hospital, and then the other office is at Emory Clifton, which is right next to the Emory University undergraduate campus and the Center for Disease Control. Our IVF lab is at Emory Midtown, and we're actually connected to the hospital. Within our practice, we have 5 REI faculty physicians, and then we have a fellowship-trained urologist who comes to our office once a week and sees patients. And we are definitely a teaching hospital. We have REI fellows. We have 1 fellow per year. We have OB/GYN residents who do their REI rotation with us. And then we always have a plethora of medical students around, usually at least 1 third-year medical student and 1 to 2 fourth-year medical students. In terms of our practice, we're relatively busy. In 2018, we had 582 cycles, and 86 of those were fertility preservation, either oocyte or embryo cryopreservation. I mentioned that our main clinic is at Emory University Midtown, and as you can see, we are right in the middle of Atlanta. And because of this, we have a relatively diverse patient practice. About 25 to 30% of our patients identify as either Black or African American. About 40 to 50% identify as white or Caucasian, with the remaining identifying as Hispanic or Asian. And then we also have a large geographic range of patients. So we get a lot of patients coming from rural Georgia, from North Florida, Alabama, South Carolina. In terms of COVID-19 in Georgia, I think some of the decisions that our government made has been in the national press, but we are relatively late in instituting a shelter-in-place order. Our governor put it in place at the very beginning of April. And then just a few weeks later, we definitely made national headlines when he decided to reopen hair salons, gyms, and bowling alleys. About at the beginning of May, we restarted doing clinical treatment in our practice, including seeing patients intermittently in the office and starting up cycles again. And then just last week, our governor signed an executive order that was titled Empowering a Healthy Georgia that ended the shelter in place for older inhabitants of Georgia. It also let restaurants fill to capacity and allowed restaurants to start having buffets again. And then in the beginning of July, they're going to allow spectator sports and live performance venues. In terms of the distribution of the cases in Georgia, this is a graphic that was taken from the Department of Health website. The red counties are the ones that have the highest number of cases, and Atlanta is in the north part of the state, as you can see, and Atlanta, Fulton County is that top red area of the state. In terms of Georgia as a whole, as of June 14th, we've had 57,681 cases and 2,451 deaths. This is another slide that's taken from the Department of Health that shows that our cases in general have mostly plateaued, but there's a lot of fear that our cases are starting to go back up as we go 2 weeks past Memorial Day weekend and with everything that has happened in our city recently. And then I just briefly want to mention that our state is one that has definitely seen a disparity in the number of cases and deaths in terms of how patients identified by race ethnicity. This is a graphic that was taken from a website that's called covidtracking.com/race, and they look at the percentage of cases by self-identified race and ethnicity. And in the state of Georgia, about 1/3 of people identify as Black or African American, but they account for about 50% of the deaths so far in our state. And just locally in Atlanta, the hospitals report that about 80% of the deaths are people who identify as Black or African American. And then of people identified as Hispanic or Latino, it's about 10% of the Georgia population, but it does account for about 20% of the cases. In terms of our center's current practice, we are currently completely open. We do have a lot of advantages in working with a large healthcare institution because we can let them help guide some of our infection protocols. The hospital has a mandatory masking protocol, so everybody who comes in has a mask on. And then we also have visitor limitations in place. So right now, there's no visitors allowed. The exceptions that we're making currently are we're allowing visitors for egg retrievals, for embryo transfers, and then also for patients who are embarking upon IVF for the consent signing. But we're not allowing visitors for inseminations or for other procedures that we do in the office. In terms of our templates, currently about 2/3 of them are in person and about 1/3 of them are via telehealth. I think we were surprised to see the number of patients who preferred to see us in person, even though our telehealth templates have been wide open. And then our monitoring schedule has certainly been modified to minimize the number of patients who are in our waiting room. We're advocating for men to do home collections for semen collections if at all possible. And then right now, our clinic is doing RNA COVID testing for all patients a couple of days before their retrievals. And then for anybody who's having outpatient surgeries, they're also getting COVID testing. The last slide I included is just a graphic that our medical director, Dr. Kwas, put together about the ASRM guidelines for our masks that we handed out to our clinic staff and our patients, and then a one-page summary that we put together for our clinic staff and our patients, just to give an example of the front-facing messaging that we're giving about the safety precautions that we put in place. Thank you all again for letting me present today.
Thanks so much, Heather. We sure appreciate it. Our next presenter is Andy Huang from Reproductive Medical Group. He practices at Reproductive Practices Medical Group, and he's a clinical instructor at the UCLA David Geffen School of Medicine. He's doubly board certified in both obstetrics and gynecology and reproductive endocrinology and infertility. He completed his residency and fellowship both at the UCLA Medical Center. Dr. Huang is a reviewer for fertility and sterility. He's a volunteer fertility consultant for the Los Angeles Zoo, and he also sits on the LA Zoo's medical advisory board. Andy?
Great. Thank you so much for the introduction and allowing me to be a part of this panel. No disclosures for me to report. So just a little bit of background about Reproductive Partners. We have 4 locations here in Southern California. We're in Los Angeles, Redondo Beach. We have an office in Orange County and Irvine. We're a private practice. We do about 2,200 retrievals annually, so we're a relatively busy center. We have 8 physicians over the 4 offices. We have about 150 staff And on a day-to-day basis, we're seeing maybe about 100 to 130 patients coming through our office. So this is just a snapshot of what's happening around us in Los Angeles County. Total cases, 73,791, and this was as of June 15th, so just a couple days ago. Total deaths, we're nearing 3,000 at 2926, and we account for a big part of California's cases at 47%. I then took a look at our Department of Health and the demographics, and you can see that a good portion, 39.2%, are kind of reproductive aged. And if you count the if you include the 41-year-olds, then it's going to be even a little bit more. So obviously the demographics includes a big portion of the patients that we're taking care of. On the bottom here, you can see the cumulative persons tested. So we're obviously ramping up our testing, which is good. And so this is kind of the state of how we're reopening. So obviously stage 1, when the shelter-in-place orders were in place, that was March 19th. Stage 2, stage 3, very recent stage 3, kind of opening up in terms of the higher risk businesses. Stage 4 is nothing set yet, so that remains to be determined. And this is a timetable of how we as a practice have managed the COVID-19 pandemic. So when ASRM issued the initial guidance, the next day we decided to complete our IVF stims. So the last stim start was on the 18th. We've completed all our retrievals by the end of March. In the end of March, we started to be, we tried to stay ahead of the curve as much as possible. So we initiated, pre-check-in triage stations. So everybody had their temperature monitored, as well as going through a questionnaire about traveling. The embryology team was divided into 2 teams. We were worried that if there was any exposure, we didn't want to jeopardize the ability to continue and maintain the care that we had initiated until we had finished all the cases. And the MDs, we function as a doc of the day center. We are a group model, so we have one doc of the day. But we were also worried that if any exposure occurred, we needed to make sure that our physician workforce would have a team that was unexposed. So our doc of the day became doc of the week. So with 8 doctors and 4 offices, we just rotated 1 week at a time. That way, at any given time, we had 3 or 4 doctors in a self-quarantine, able to come out of quarantine if anybody was exposed. In April, we furloughed about 2/3 of our staff, so about 100 staff were furloughed. We were only doing OB and urgent care visits. No partners were allowed into the office. All diagnostic testing was deferred. All consultations were to telemedicine. Again, the MDs maintained their quarantine rotation, and we were lucky that we had the PPP loan confirmed. On April 13th, when the ASRM task force had their 3rd update and fertility care was issued as an essential service, we made the decision that we were going to reinitiate care, focusing on the priority to our women who are older with diminished reserve. And we were also trying to limit it to just 4 stim starts a day so that we wouldn't overwhelm our staff. May 4th, we resumed egg retrievals. May 18th, we decided we would resume transfers with an appropriate informed consent. A lot of policies and procedures were initiated, and so the pause in April was very effective at helping us do things safely. So we limited it to 2 to 3 patients in the waiting room. If it exceeded that, then they were told to go to their cars, and we would text them. We spaced out all the patients so that we wouldn't see more than about 6 or 7 per hour. Telemedicine was continued. The MD quarantine rotation was also maintained. Mandatory face masks for patients and staff was also initiated, and the doctors continue to have weekly, if not twice weekly, practice meetings to stay on top of the changes. This month, we hired all of our furloughed staff, with the exception of those on FMLA, and the hope is that we'll gradually increase to 100% of capacity of what we're doing. COVID-19 testing is offered to all staff that has traveled or might have been exposed, and we continue to do COVID-19 testing for any patient that would receive anesthesia or have any procedure. Yeah, and that's it. So that's how we've been, doing our best to stay ahead of things here in Los Angeles area at Reproductive Partners.
Thank you very much, Andy. We appreciate that. Emily, I think you are up next. And Emily is a professor at the Feinberg School of Medicine. She completed her residency at Duke and then her fellowship at Washington University. She is also doubly board certified in both obstetrics, gynecology, and reproductive endocrinology and infertility. Emily?
Great, thank you very much. I have no disclosures. So just a brief description of our practice. We are located downtown Chicago. We have satellites in Highland Park, which is about 20 miles north of the city, and Oak Brook, which is about 20 miles west of the city. In 2018, SART statistics showed we did 2,318 cycles. Of those cycles, we have a robust fertility preservation program with a really busy cancer center. 132 embryo banking cycles in 2018 and 263 egg banking cycles. We've got 10 physicians. One of them is our department chair, so he's not that active with us, but otherwise a pretty busy practice. So just to kind of talk about how COVID made its way into Chicago and when we started acting on things, there was a case that was announced early in January of COVID, and then shortly thereafter, actually there wasn't a lot of activity after that, but then on March 8th, they announced the first person-to-person COVID case transmission in Illinois, and that's when things started to get a little aggressive in terms of shutting things down. That week between March 8th and March 15th, there was lots of discussion of would there be a shelter in place and when would that start? So March 15th, it was a Sunday, and Northwestern Medicine had an emergent conference call for all surgical services, and they placed all non-urgent surgical cases on hold. Then, as you guys know, March 17th, the ASRM COVID-19 task force issued their guidance, and then on March 20th, the governor of Illinois, J.B. Pritzker, issued a shelter-in-place order. Our response started March 15th, where we decided at that time to complete all retrievals for patients who were currently in stimulation. We deferred any new cycle starts, including those for egg retrieval and frozen embryo transfers, but we decided at that time we would continue stimulation and retrieval for our medical fertility preservation cases, again, because of that robust and strong relationship with our cancer center and other cancer centers within Chicago. Our clinic, we shut down our satellite locations. We deferred all diagnostic testing. We continued in-person OB visits and urgent visits, and all other visits were converted to telemedicine. Just to show you where we're located, we're in downtown Chicago, and the dark blue highlights where most COVID cases have been diagnosed. And then you can see another clustering in St. Louis. But otherwise, the rest of the state, it's been pretty slow to see a lot of COVID cases. Next slide. This is just demonstrating when the COVID cases have been diagnosed in Illinois. And as you can see right now, fortunately, we're seeing a decline in new cases. And as others have discussed, it'll be interesting to see what happens the post-Memorial Day and post other events that have occurred that have brought people in closer proximity. As you can see, though, back in early March, when our shelter-in-place order was placed, and when ASRM issued its guidelines, there really weren't that many cases, but it abruptly increased thereafter. Here's a slide of deaths in Illinois. And again, most of these deaths and cases are occurring in Cook County, where Northwestern is located. This is just a summary of where we're at right now. I pulled this off the Cook County Department of Health the other day. So in Illinois, we've had 1,333 confirmed positive cases and 6,398 deaths. In Cook County, about 5,000 of those deaths have taken place in Cook County. Our governor, similar to the governor of California, has announced phases for recovery. We're currently in phase 3 of recovery, where manufacturing, offices, retail, barbershops, and salons can reopen to the public with capacity and other limits and safety precautions. I will say that this is quite restricted still, though. A lot of places have not opened, and if they have, they've got limited hours and limited number of people that they'll allow in. We're allowed to have gatherings of up to 10 people, Most people are wearing face coverings out and about, but certainly in any closed spaces like stores, you're required to wear a face mask if you go in. In terms of when phase 4 will happen, we're still not sure. We haven't heard, but that will allow for broader reopening. So our current state at Northwestern, we're working at about 60% capacity for IVF. Our main location is open with one clinic MD doing all of our saline sonohistograms and OB checks. We are back to doing diagnostic testing, and we're allowing extended hours for our IVF monitoring with specific times in place for each patient to come in to make certain that we don't have more than 2 to 3 people in the waiting room at any given time. Like other practices, we are not allowing partners to come in. We're requiring at-home semen collection, and we are starting up with inseminations again. Our 2 satellite locations are open for saline sonohistograms and OB checks with our nurse practitioners, open for diagnostic testing and IUIs, and again, they have extended hours and appropriate screening in place. And we are continuing all of our new patient visits and visits that don't require exams to happen via telehealth. One thing that, similar to Emory's situation, we're quite fortunate for is that the hospital does allow for a lot of resources for screening and PPE and shared resources to make certain people feel comfortable coming into our space. A few changes that we've implemented to highlight: we are giving COVID counseling to all of our patients who are starting new fertility treatment cycles. We have a group of nurse practitioners who are calling all of our patients to just discuss the risks of COVID, what's known and not known about COVID infection and pregnancy, to make certain that all patients are comfortable coming back into our offices for treatment, and also discussing what safety precautions we've put in place to prevent transmission of COVID within our office. We're also doing COVID-19 testing at baseline for all of our fresh egg retrievals so that we can feel pretty confident that when they come in for a COVID-19 test before their egg retrieval, it will be negative. The reason being that our anesthesia team will not proceed with putting someone to sleep who is COVID positive. The exception being if it's an urgent case, a medical fertility preservation case, if they're positive and asymptomatic, we will proceed with their case. I guess that's it. Thanks.
Okay, thank you very much. I think I'm unmuted now. So our final presenter before me is going to be Brad Senstra. And Brad is the Executive Director at Seattle Reproductive Medicine. There are 13 physicians in that group. They serve Washington State, Alaska, Idaho, and Montana. Brad's been with SIRM for 12 years, and he has a background both in finance and in contracting. Brad, welcome, and thanks for joining us.
Thanks, Kaylin, for that introduction. I appreciate it, and thanks to ASRM for allowing me to give a little bit of our experience here during COVID. I can say I have no disclosures. Just a little bit about SRM here in Seattle Reproductive Medicine. We have 6 locations throughout Washington State. As Kaylin mentioned, we service patients in Washington, Alaska, northern Idaho, and eastern Montana. And in fact, if you take Washington State and Alaska, we have about 65% of the market share for those 2 states. We are a full service program, including egg freezing. We have on-staff urology, acupuncture, nutrition services, mental health services, et cetera. So we try to provide the full breadth of services. And it's a little difficult to measure number of cases, so we look at number of retrievals. And last year we did slightly over 2,000 retrievals, and we hope to do the same this year. So this is just a quick status. The statistics I'm showing here are in King County, and that's where Seattle resides, and 4 of our 6 clinics are in King County. So this is pretty representative of Washington State. And you can see the number of infections, positive cases here that run through about June 10th when I pulled this information. And we've had a pretty significant decrease in the number of cases that we've seen. The arrows that I put in there, which I'll get into in a minute, but that basically, the first arrow is where we stopped all cases and all services other than telehealth. You can see that follows directly after the ASRM guidelines were put out. And then the second arrow was where we started very limited procedures and IVF starts, day one starts. So we weren't actually in the lab yet at that point. And then the final arrow was really where we started back day ones for any and all of our patients. Additional statistics, you can see that we've had about 8,700 positive cases in King County and 574 deaths. We actually think that's pretty low given the metropolitan area here. And then we can also get new statistics on a daily basis. And right now we're seeing between 25 and 50. This happened to be a big day, I guess, when I pulled this last week, but about 25 to 50 new cases per day. Similar to other places, our governor has put together by county a staged opening program, stage 1 through 4. Unlike Atlanta, we are very conservative here about opening and moving through the stages. And in fact, King County is still in stage 1, although they call it a modified stage 1. So they have pretty heavy restrictions for retail and service industries. For instance, if restaurants are open, I think they're at 15% of capacity unless they're outdoors, and then it goes to 25%. Similar for barbershops and things like that. The one thing to note, though, is there is no restriction on healthcare services any longer. So elective surgeries and all of that are open in this modified stage 1. So a little more detail on what we did following the announcement by ASRM. We stopped all IVF with the exception of medical fertility preservation. So we did keep doing that throughout the entire time. We closed 2 out of the 6 satellite clinics, and that was more just from a volume perspective, furloughing staff. We implemented that all new patient visits and consults are telehealth only, and in fact that continues today. So our policy, even as of today, is 100% of our consults are telehealth. We have no possibility of them coming into the clinic. We also implemented screening for all staff and patients. So we have stations set up just outside of all of our clinics that require masking and screening questions as well as temperature check. So once we had our pause for about 3 weeks, we had a slow start on April 4th. April 4th represented the day ones for the IVF cases. And those were really for patients who were waiting that we thought had a higher need from a timing perspective, so over the age of 38 or AMH less than 1. All patient types then started day 1 as of June 1. So once we felt comfortable that our procedures in the clinic were strong enough that we could keep social distancing safe, we started with all patient types starting June 1st. And now that it's June 18th, we're getting to the point where we're back to pre-COVID volumes, at least as it relates to our embryology lab and our insemination services. But we continue, and the most important thing for us is social distancing and making sure that our staff and our patients are safe. Similar to others, we have no partners or visitors in the clinic, but we include that for any patient type. So whether that's for retrievals, any procedure or anything, visitors are not invited into the clinic. We have special waiting areas outside of the clinic for all of those patients. And social distancing plan implemented practice-wide for both patients and staff. So our ongoing plan, as I mentioned, right now we're basically all of our services, even though we have different operating procedures, all of our services are now open and available. But we will continuing all of our social distancing throughout the full year of 2020 to include the no partners or guests guidance, telehealth for all new patients and follow-ups. The only exception there would be if we run into payment and insurance issues, which we hope we will not, but we continue to watch that closely, as I'm sure all of you are. And we have implemented quite a staff working from home and we continue to ramp up resources such as laptops and other things so that we can continue that in the long term. Obviously, we will continue to monitor daily infections in King County and throughout Washington State. And if we continue on the current trajectory, we'll be good. But if they start to rise, we may have to change how we look at things. And of course, state, county, and I neglected to put ASRM, but of course, ASRM guidance will sort of watch as we roll into the fall to see if we can continue under our current process or whether we need to take another pause. But we don't plan on changing any of our continuing new processes, at least through 2020. Thanks for your time.
Thanks so much, Brad. So I'd like to go through my presentation now. I have no disclosures either. To tell you a little bit about Texas Fertility Center, we're a private practice located in Central and South Texas. We have 6 offices, including 3 in Central Texas, everything from Round Rock to South Austin. And then we also extend to South Texas as well, New Braunfels, San Antonio, and Corpus Christi. We have 7 board-certified REIs. We have 2 full-service IVF laboratories, 1 in Austin, 1 in San Antonio. We have 6 andrology laboratories. And 2018 start data showed that we did 2,272 cycles. To give you a little bit of background in Texas, and it's interesting, it's really fascinating to me to hear different people around the country with their different perspectives. I have a very different perspective being in Texas because we were spared a lot of this heartache early on. We've had a little bit more involvement more recently, but not early on. March 4th was the first time that a Texan was reported with COVID-19, but there's actually some evidence that, some evidence that this virus may have arrived as early as September 2019. In fact, to give you some interesting perspective, in January, 14 of our nurses were out with fevers ranging from 101 to 104. They had coughs, they had body aches. They all tested negative for the flu, and at the time, there was no COVID-19 testing. A couple of them have had antibody testing since then that showed that they were negative. The rest have not been tested, but we have some reason to believe that, in fact, our office may have been hit as early as January. On March the 11th, Greg Abbott, who's the governor of Texas, declared a state of disaster for Texas, and this affected schools, restaurants, bars, gymnasiums, et cetera. Everything was closed. On March 22nd, the governor suspended all non-medically necessary surgery, which presented a real problem for us because of the definition of what's really medically necessary. And I'll get to that in a few minutes. On April 17th, the governor closed all schools in Texas for the 2019 and 2020 academic year. This included everything from elementary and pre-elementary school all the way through graduate schools. On April 24th, the governor decided to allow elective surgeries to resume. Many businesses were allowed to reopen with curbside service, and restaurants were opened at that point in time to 25% capacity. They've since been open to 50% capacity. And on May 1st, more businesses were allowed to open. This shows confirmed infections in Texas and where they are. Interestingly, when you track, like we do, we track on a daily basis all the information that comes from the Texas Department of Health, and our incidence of positivity, in other words, the percentage of people who are tested for COVID-19 who actually test positive, has run approximately 5.9% since March 23rd. We've had a blip up last week to about 7.2%. We're back down to about 6.2% now. So even though you'll read in the news that Texas is reporting more and more cases, because the incidence of positivity is the same, we believe that that's really a result of a marked increase in testing. This shows the COVID-19 status and history in Texas. You can see on the top bar, the bar graph there, daily new reported cases, and on the bottom is daily new fatalities. So you can see that our fatality rate has remained very low. There are, some minor variations and spikes here and there. The daily reported cases have increased, but again, this has occurred since approximately the 10th of May. And again, this is when we had a real ramp up in our testing. So how did TFC respond? And our response, as you'll see, was very different to most programs in the country. We never closed. So despite Governor Abbott's general administrative order that stopped all elective procedures, despite the ASRM guidelines, and despite an unannounced inspection, and I put that in quotes, by the Austin Police Department because we were turned in apparently by one of our competitors. We had 3 very nice, very respectful members of the Austin Police Department show up. They came in and they told us that we've been reported as a non-essential business. It was still operating, And not only that, we were reported as operating in violation of code. They came to our office. They were in the downstairs lobby. We screened them just like we screened everybody else. So they had their temperatures taken. They had to fill out written questionnaires. And only after we cleared them were they allowed upstairs. They came upstairs. They toured our facility. They were very embarrassed and very apologetic about being there. They were there for about 8 or 9 minutes. They came back to us afterwards, told us that we were considered an essential business. We were allowed to stay open, and they told us our policies were exemplary. And in fact, they even gave us their business card, and they said if anybody hassled us in the future, to refer them to these guys who came to see us, and they said they would take care of it. So how did we respond? We had a 4-phase plan that we developed that we actually implemented on March 12th. Eventually, we went all the way through phase 3, which, as you'll see in a minute, includes all the things that we'll talk about. Phase 4 was where we would actually close our offices, and we never reached phase 4. In light of the governor's executive order, which stopped all elective procedures, his executive order was somewhat ambiguous, and there were 2 clauses in there specifically. One included the word "or," and one specifically said that nothing in that order would cause procedures to be stopped if, in fact, the facility in question did not use PPE that would be used by hospitals and did not impinge on hospital capacity. And we believe that we fell under those guidelines, and so we hired Dan Ballard, who's one of the leading healthcare attorneys in the state of Texas. He evaluated our policies and procedures, determined that we were in compliance and we could remain open. We then consulted with a couple of different Texas state representatives, and we consulted with the governor's chief of staff as well. And we were told that, in fact, we would be allowed to stay open. We subsequently applied for a PPP loan, which allowed us to continue to maintain all of our staff. So everybody remained full-time, even though we didn't have them working full-time. Everybody has remained on full payroll. So everybody's been paid in full for all the work that they've done. Even though initially we scaled our staff back to working 20 hours a week, we did encourage people when possible to work from home. We then subsequently resumed full-time operation on June 1st, and we're back to 100% of capacity. Our retrieval volume, we normally do about 90 retrievals per month. In March, that number was down to 54. In April, we only did 19. In May, we did 65. And in June, we're projecting actually now 110 retrievals for this month. So what's our current status, our near-term plan? As I said before, TFC has remained open. We have a mandatory masking protocol that's been in place since we imposed our phase 1 protocol. We take staff's temperatures twice a day. All patients are evaluated in our building lobbies before they're allowed to come upstairs into our offices. And we like to refer to our offices as a safe zone and a disease-free zone. And the reason we're able to do that is because since March 23rd, since all of this started, we've not had a documented infection in any single patient, any staff member, any physician, or any family member. We do have a no visitor policy, so we don't allow vendors. We don't allow any partners to come upstairs, with the exception of patients who come in for embryo transfers and patients who come in for OB sonograms. We're asked repetitively about patients coming in for new patient visits, et cetera, and we're very strict on this rule. We are offering telehealth for all new patient visits, all follow-up visits, and all pre-ops and post-ops are offered telehealth primarily. Patients can elect if they'd like to come into the office, but we strongly encourage telehealth. Our waiting room is limited to 8 people, compatible with social distancing guidelines. Everybody else waits downstairs in their cars, and we call them on a cell phone when it's safe for them to come upstairs. We have not required COVID testing before retrievals or outpatient surgeries. Likewise, the hospitals in Austin have not required COVID testing before retrievals or outpatient surgeries as well. And again, as I previously stated, we've had no documented infections in anybody affiliated with any of our practices. So our long-term plan and improvements we've made, we intend to continue to offer elective telehealth. We do believe this has made us much more efficient. We plan on continuing patient screening indefinitely. We've moved all consent form processing to the online portal that we have. And we also have an educational portal that we've opened up now for webinars, for our biweekly IVF orientations, and for all podcasts. We've also started a nationwide podcast called Fertility Docs Uncensored that's really gaining in attraction. So I like this quote that Andy Grove, who's a former CEO of Intel, states, and he said years ago that in response to a crisis, poorly run companies fail average companies survive and well-run companies thrive. And I strongly believe that all of us are going to come out of this better, and that if we learn from this crisis, we will all benefit, as will our patients. So I'd like to open everything up now to questions and answers. What we would like for you to do, if possible, is to refer your questions to a specific faculty member. Otherwise, I'm just going to try my best to shoot the questions around to different faculty members. And so we are open now for questions. Okay, the first question I see is, are any programs accepting international patients? Brad, you want to take that?
Yeah, it's easy for me. I'd also like to hear Andy's response to that, because I know they have a major international program. We don't have a large international program, and right now we are not accepting international patients live in the clinic.
Yeah, this is Andy. We similarly have not seen international patients. We have a small set of patients that come from Asia, and so we've held back on seeing them. So they're all on hold right now.
Is anybody requiring, Heather, I'll toss this one to you. Is anybody requiring any kind of quarantine before treatment or before initiating treatment?
We're not requiring a quarantine before treatment, but we are asking anybody who's traveled in the last 14 days to self-quarantine at home. And so if patients ask me about traveling, I'll say we would like you to travel before that 14 days of your treatment start.
Okay. Are any of the rest of you requiring any kind of quarantine?
We previously did. Here at Reproductive Partners, we previously did. But we realized people were probably quarantining kind of in states that were probably safer than California. So recently we relinquished that quarantine. We do have a policy that we ask if anybody traveled that, everybody comes in with their appropriate PPEs. And within 5 days of coming back, we will do a COVID-19 test just to kind of get a little bit of reassurance.
Got it. This is a question that I've been asked repetitively, and I've looked for the answer. I can't really find a definitive answer. Does anybody know if COVID-19 virus can survive in liquid nitrogen? Okay, you guys obviously have the same perplexed looks on your faces that I did, and I'm sorry you can't see my perplexed look on my face. My webcam works beautifully. I've done a bunch of these, a bunch of different webinars, and of course today is the one day that it's not working, so I'm sorry. The question obviously refers to the fact that, if the virus can survive, is there a possibility that frozen embryos could subsequently get infected, and could they potentially be a source of transmission of the virus? Anybody have any thoughts?
It is a very fragile virus from what I understand. And I think from the prior SARS outbreaks, there's no data that can survive liquid nitrogen. My husband's an internist. That's what he told me about the viral particles. He paid attention more in medical school than I did.
Got it. Anybody else have any thoughts? So let me ask you a question. Is anyone aware of anything besides the one case report that came out of China that was really confusing? Is anybody aware of any documentation of vertical transmission from mother to baby? So the biggest report that I'm aware of is this Chinese study. They looked at 33 babies that were born, 33 mothers that came in infected with the virus, and they delivered. And of those, there were, I think, 3 cases where the babies turned out to be positive. But when they looked back at those specific 3 cases, the cultures were negative for amniotic fluid, negative for the umbilical cord, and negative for the placenta. And in addition, the babies themselves were not cultured in the first 48 hours of life, and yet they'd been given to the mothers. So the mothers had been handling the babies, breathing on the babies, breastfeeding the babies for the first 48 hours of life, and then 3 babies subsequently tested positive. All the babies did well. They all went home. But I'm not aware of any vertical transmission that's been definitively documented. And I also have gone through the literature, and I can tell you that with MERS and with SARS, there's not been any vertical transmission that's been documented for those either. So unless anybody has any evidence to the contrary or data to the contrary, I'm going to continue to operate under that assumption that that's the latest and greatest info we've got. Nobody have anything else? Nothing more recent. Okay. The next question is, do patients sign any specific COVID-19 risk consent forms prior to proceeding for ART? Brad, you want to start with you, and then we'll go around the room?
Yeah, we do not have that in place at this point.
Emily?
Yeah, we do have a counseling process that takes place over the phone. Our nurse practitioners reach out to anyone who's initiating a fertility treatment cycle, discussing what's known and not known about COVID-19, and also discussing the fact that we will cancel the case if someone becomes symptomatic with COVID-19 during their treatment cycle. So for IUIs, if they become symptomatic or their partner does, they will be canceled. And then again, we require that all of our stimulation cycles have baseline COVID testing that's negative before they start.
Thank you. Heather, how about you?
We don't currently have a written consent in our clinic for starting treatment, but we do have an outline that we go through with patients before they start their IVF cycles. At Emory, we're able to proceed with retrieval. If we have patients that are positive, we would obviously do a freeze-all. So we have outlined series of hypothetical questions. If this were to happen, this is what we would do as a next step. And obviously, we would recommend not proceeding with any treatment that would involve a pregnancy if someone was testing positive.
Andy?
Yeah, we do have an informed consent that everybody has to sign and review before proceeding with treatment, whether it's for stimulation and egg harvest and frozen embryo transfers. We also do COVID-19 tests before stimulation, as well as at the time of trigger prior to the egg harvest. And the patients know that anytime they come back positive, which we haven't had, so thankfully, or anybody is symptomatic, that their cycle is canceled.
Got it. Yeah, we also have a consent form that we use, but we do not do testing, as we said. Okay, what criteria are you all monitoring that might make you decide to pause care again, if any? Andy, I'm going to start with you and work backwards.
Yeah, so what criteria is that we would kind of go back to a pause?
Yes.
So we would go back to a pause if, I mean, we're pretty diligent about, and we even are testing staff that has any risk of exposure. But if we saw, I mean, recently we had a scare in the sense that we did have one staff member test positive. Now, she had already called out. She called out, stayed out, wasn't feeling well. And so then we had her get tested, and she tested positive. Immediately, we tested every single person in that office, whether they had direct exposure or not. And so we were very happy that everybody tested negative. But we had contingency plans in place that if there was any positive, we would have to really think about that office potentially closing.
Sure.
So, you know, it's reassuring that, you know, the policies we have in place. I mean, all of our staff members have to keep on an N95 mask from the time they check in after they get their temperature screen to the time that they clock out. So, and it's nice to hear that with those measures in place, that we've been able to mitigate the risk. So, yeah, I mean, if people started testing positive in the staff, we would have to very seriously think about, you know, hitting that pause button again.
So your decision-making process is really going to be based upon your staff and what you see in your own office. Any criteria for your community?
I mean, if we see kind of an uptick, I mean, with the kind of recent reopening of businesses, I'm sure we'll see a re-uptick. But no, I mean, we'll take the Department of Health's recommendations. But right now, you know, as long as we're able to safely have the patients come in and screen them appropriately, you know, we'll follow the Department of Health's recommendations. But so far, we feel like, you know, we've been doing things pretty safely.
Thank you. Heather, how about you? You guys monitoring anything in particular?
I think we're definitely monitoring ASRM's updated recommendations that they're coming out with on a monthly basis now. That's guiding a lot of our practice. And then also just because we're part of a large institution, just like Northwestern, I think we also have to follow institutional guidelines. So if they start limiting the amount of outpatient surgeries that we're able to do, then that may make us take a pause as well. And I think a lot of that is based on just what is happening locally within Atlanta and within Georgia. We're unfortunately an outlier in terms of when we open back up the state. And so I do have fear that once fall happens that we will be an outlier in terms of the case incidence rate.
Emily?
Yeah, similar to what Heather said, our anesthesia staff, hearing their stories of what they've experienced in the ICUs and some of the emergencies they've dealt with, we recognize that if there's an uptick in cases in the community, our anesthesia staff will be taxed to help us out. And then similar to what Andy said, we're really monitoring the health of our staff, primarily the lab. I like to joke I can do just about anything in the office except for what the lab does. So we've actually reached out to some of our other centers in town that we have good relationships with and talked about worst case scenarios, what would happen if our whole lab went down. But my hope is that we've learned to be nimble and we can keep some level of practice going, either increase cases in our office as COVID decreases and decrease the number of cases we're putting through as COVID increases. But hopefully we're in a good trajectory now, and we'll just be able to keep growing the practice.
Thank you. Brad, anything that you guys are monitoring?
No, it's similar. Obviously, the staffing is the key piece here. We feel like during the pause, like a lot of us, put in place procedures that can keep us safe and keep our patients safe. So it's really more of an internal. We're monitoring local cases, and I think it would have to be a pretty large uptick in cases for us to consider changing our current policies here. So that's what we would be looking at, though, is local cases, if anything, outside of internal infections.
Yeah, and I think I would really agree with you. That's the same thing that we would be following here. You know, as I said before, we never closed. We were really reticent to close, and for a lot of different reasons. The next question that I have for you all that I'm really curious about is, in your communities and in your patient population, as unemployment has really ticked dramatically higher, the concern that I think a lot of us have is that as people lose their jobs, they lose their insurance. And when they lose their insurance, they lose their ability to go through fertility treatment. At least a lot of people do. And this is one of the driving factors that kept us open. And I can't tell you how many people have come to us, how many patients have come to us so grateful because, in fact, they have lost their jobs. They are worried about losing their insurance. It was critical to them that they be able to get a chance to cycle before they lost their benefits. And I'm curious as to, in each of your individual markets, what you think the percent of patients that you see who have come in expressing similar concerns that they're going to lose their jobs and their benefits. Brad, you want to start with you?
Sure, and we're lucky in Seattle where we have a very highly tech population, and I would say more than 60% of our insured population is covered by Progeny. So we're seeing, and those are all large self-insured employers. So we're not seeing a big change in the insured population. We're probably 60 to 70% of our cycles are covered by insurance. So really it's the cash paying patients that we're worried about. We didn't have insurance in the first place, but then are losing their jobs and not able to continue that. So, our goal is to make sure we're looking at our financial programs and costs so that we can reach out and service patients who may not have the insurance and didn't have the insurance but are coming across more financial difficulties. But like I said, from an insurance standpoint, we haven't seen a lot of loss yet.
Thank you. Emily, how about you?
Yeah, similar to Brad's situation, being in Illinois where there is a pretty progressive fertility mandate, a lot of our patients have insurance. We haven't seen a hit yet in regards to people being unemployed and not having benefits, but I'm certain that that's going to be an issue moving forward.
Yeah. Heather?
We haven't seen a direct drop yet. I think it's hard to tell because we were on a pause for about 6 to 8 weeks. And so I think that some of our volume is just recuperating from that. A lot of our patients are healthcare employees, and so they fortunately have been able to keep their healthcare insurance because they are needed right now. And then a lot of our other patients are self-pay because Georgia is not a mandated state. So I would say anecdotally, we're seeing more patients who are interested in oocyte cryopreservation, just a delayed fertility than we were even a few months ago. But I'd be interested to see what's going to happen in 6 months.
Yeah. Andy?
Yeah, same with what everybody said. Our payer mix is pretty spread out. We haven't seen a drop, but I think it's because we took a pause in April. And so, May and June, it may be pent-up demand on patients that have been kind of holding off and now coming back. It'll be really interesting to see kind of the next couple of months and how the volume is there. But when I'm with patients and I am asking them how are they doing, I am surprised at how many of them are still working from home. So that's good news. So as I talk to them, most of them are working from home. I haven't heard much of the job loss that we're hearing around the country. And maybe that's unique to kind of our demographic, but for the most part, I'm reassured to hear that the patients that we're seeing are still kind of employed and they're just working from home. And so, hopefully it won't be, the volume in the next couple of months, hopefully it won't be a dramatic loss.
Thank you. So this is a question for me, and that was, how do you handle any staff that were nervous about coming to work? And the answer is, we never force anybody to come to work. So, patient or staff members who felt comfortable, and we did have questions, to be honest with you, because every single one of our competitors closed. And so we had a couple of questions from staff members of, wait a minute, why are we open and everybody else is closed? And so we just kind of walked them through it and what our rationale was and why, we felt that we had fought for decades to have infertility recognized as a disease, and we didn't feel that that we should curtail treatment. And if the governor's office said that we could stay open and we were in compliance, and the police said we could stay open and we were in compliance, we felt very comfortable that safely we could stay open. But we told anybody who was uncomfortable about coming to work that they could, number one, work from home if possible, and number two, there were several policies in place that the government had put in place that would allow them to take time off where they could still be paid. Anybody else have any other thoughts about that?
We did the same thing. People who are nervous and hesitant, we let them work from home. So, they could, be phone nurse from home. We kind of had laptops in place so that they could, be working at a safe, whatever everybody felt safe doing. So people who didn't feel safe, they took, extra time before they came back. And so, now we're seeing almost 100% of our staff members be back. But we similarly only had people who felt comfortable at work if they, for family reasons and other things. So we constantly are assessing kind of how our staff feel.
Okay, so we'll take just a couple more questions. We're just gonna go over a few minutes if that's okay. And again, if anybody has any questions, if you would go ahead and send them in quickly. The next question that I had, hang on one second, was about masks. I think we've all addressed the mask issue. Are any of you in a practice where the physicians do not wear masks at all times? No, I think we've addressed that. I think everybody wears masks at all times. Next question, would you proceed with a retrieval in a COVID positive patient who's at high risk for hyperstimulation syndrome? Emily?
Well, our hope is that we won't get into that situation because, again, we're doing baseline testing on all of our patients for COVID-19. We have a pretty robust COVID-19 obstetrical unit too, where there've been lots of tests, and the incidence of asymptomatic carriers is about 4%. So about 4% of people are testing positive who are asymptomatic. So if they're asymptomatic, if they're negative at baseline, our hope is that they won't become positive during their stimulation. But I suspect if they were high risk and we were worried they would get ill, we would do something to try to do their retrieval. Our difficulty is our anesthesia team is pretty aggressive at stating that they believe there's increased risk if somebody is COVID positive for placing them under anesthesia. Apparently there's some data to support that. So we'd have to have a sit-down talk with our anesthesia team and make an individualized decision about that.
Sure. Heather, how about you?
We have talked about this with our anesthesia team, and they said that if we did have a COVID positive patient, they would feel comfortable proceeding with an egg retrieval and doing a freeze-all. I think we would counsel them, like Emily said, about the potential increased risk for their health of going through anesthesia, and potentially even do it under a very, very light MAC with maybe even local anesthesia to try to reduce the amount of anesthesia that they're exposed to. We already wrote protocols in place if one of our patients does come back positive for COVID. So if we find out 2 days ahead of time that they're positive, in terms of the cleaning protocols that we would use for our procedure room, in terms of distancing for our clinic staff, the N95s that we have on hand for all of our staff and our anesthesia team. So I think it's something that we would be able to do after counseling with the patient.
Right. Okay, last question. This question is, are you proceeding with donors? I'm assuming they mean egg donors. And if so, what are you doing differently? Andy?
Yeah, so for a while we put a pause on egg donors. We were worried about traveling. So, and then we gradually lightened the restrictions so that if they were driving and not flying, if they didn't have to go through 2 airports on a flight, we would take care of them. Same thing for gestational carriers. Since then, we've also kind of lightened our restrictions on that. So we are proceeding very recently with egg donors and surrogates.
Great. Emily?
Same. We're testing our donors at baseline, though, for COVID, setting up local testing if they're traveling. And we are also testing our gestational carriers, given the high stakes involved for everyone, and then doing their FDA questionnaires pretty aggressively to make sure they haven't had fevers and things like that, and make sure we have documentation in place that they're COVID negative.
Heather, what are y'all doing for donors?
Similar to everybody else, we've just restarted donor cycles and are asking them if possible to try to quarantine apart from having to be in the airport. And like Emily said, being very stringent in terms of the FDA questionnaires.
And Brad?
Yeah, it's similar to everyone else. We started on June 1st with all patient types that included donors. I think 99% of our donors, if they travel, they're traveling by car. They're all very local, so we don't really have a issue with that. But otherwise, we're fully open with that.
Great. Well, listen, on a personal note, I just want to thank you all so much. It's so great to see smiling, happy, healthy faces out there. And I just thank you so much for being so committed to providing such excellent care to your patients and for being there for everybody. So thank you so much for being involved in this process and in this program. And thanks for taking time out of your busy days to join us.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Silverberg, for moderating this session. Thank you to our panelists and to our attendees. Thank you for joining us. You will receive a survey by email after this session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Watch your email for notification of the next scheduled webinar. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.